Right. So the big part of the vascular phase, there's multiple protein systems working. One of the complement system is activated. Prostaglandins are created because of the release of arachidonic acid. Mast cells release histamine. So we get vasodilation, and we get the redness and warmth, which is just occurring in a place we can't see now, and we get the um, contraction of endothelial cells that allows for fluid and proteins to leave, and the increase in oncotic pressure even pulls more fluid. So we start to have edema. Because those pores are open and we have allowed fluid to come out, um, those activated endothelial cells will release integrin and selectin and will pull neutrophils to the endothelial layer, which is margination. It's like Karis is starting to type something, and then we get the neutrophils will transmigrate through the pores and get pulled into the process through chemotaxis, and then begin phagocytosis. And in the case of bacterial infection, the neutrophils always increase the amount of exudate, no matter what, even if it's just foreign material or just some kind of irritation or regular tissue injury, because they will phagocytize foreign material or cellular debris, which will interact with lysosomes, and then the neutrophil will necrose and open its cellular contents, and those lysosomes help with wound debridement. But the exudate itself in this situation would be purulent with a bacterial infection, and then what has to happen in order to get the adaptive response? We have to make the connection between the innate and adaptive immunity. No, I'm waiting for you guys to answer the question. Ask the question. What's the connection between innate and adaptive immunity? How do we start that up? The lymph system. So that's part of it. We will drain, and that is the other part of it. So we have all this exudate, then will drain into the lymph vessels, into the nodes, where if there's a bacterial component to it, can interact with a immature B lymphocyte. And we have the monocytes that activate into macrophages that present antigen on their surface to immature lymphocytes in order to achieve antigen selection. And then there's clonal expansion. So whatever it is that is the perfect um, response to this infection, we will cause proliferation of that cell line. So you have to keep that in mind. Anytime we're talking about, I know, right? That's because I have said it like a gazillion times. But you have to keep that in mind because, of course, that explains any symptoms with respiratory infections, whether they be viral versus bacterial. There's going to be some degree of tissue injury, swelling. The difference is in the degree of exudate between a bacterial and a viral infection, because bacterial infections, because they are outside of cells, there will be an increase in phagocytosis and neutrophil response, which leads to that shift to the left, and then there'll be a greater amount of exudate. Then if it was a viral infection, because viruses are intracellular parasites, and so there's a less of an exudative response from neutrophils, because the neutrophils are not going to eat our cells. We have to wait for macrophages. We have to wait for the NK natural killer cells and the cytotoxic T cells to actually damage the virally infected cells, and then the macrophages clean up that mess. So it is slightly different in terms of the degree of exudate and the differential of the CBC. Not yet, because I haven't shown anything yet in terms of sharing the desktop, because I was making you go over the inflammatory process. So now we're at infections. Those infections could be viral or bacterial, and if they are going to manifest in the conductive system, then we would expect certain types of symptoms based on where it is. So if I have a throat infection, which means I would have swelling, potentially a large amount of exudate versus a smaller amount of exudate, pain when I swallow, those kinds of things I would expect related to an infection in the pharynx. If I had an infection in the larynx, what types of symptoms would be expected? Loss of weight. So if my inflammation takes place in those vocal cord area, then yes, I will have a hoarse voice, or you won't be able to hear my voice because there'll be too much inflammation between the folds in the larynx. If I had laryngotracheal bronchitis, is the fancy way to say that somebody has the croup, which is an inflammation of the larynx, trachea, and the first part of the bronchus. So an infection in the upper airways. This is seasonal. It's most likely to be viral. This infection has what's called a steeple sign, so it might be harder. I'm not sure how well you can see this, but this is someone's neck down into their clavicles, top of the rib cage. This would be the main bronchus, which you can see has become a steeple here, which should be open into the trachea because of the degree of inflammation, which is different than epiglottitis because, sorry, what did you say? It's no, croup. But it's the official term is laryngotracheal bronchitis, sorry. Where's the epiglottis? What symptoms would I have if I had epiglottitis? Right, so the epiglottis is a piece of tissue that's supposed to protect the larynx when the person is eating. So if the epiglottal tissue gets too inflamed, it can block both the larynx and the esophagus. So if that occurs, so here's the epiglottis. If it gets very inflamed, then I certainly can't get any air down there, but it's also going to cover the esophagus, which means not only will the patient have inflammation, but they also won't be able to swallow. So that person will be the drooly patient, not just the swelling. So those are different examples of conductive airways being inflamed. Certainly bronchitis is another example where the smaller, so if we go from the larynx to the trachea to the two main stem bronchus, and then the bronchi, those are the ones that get inflamed with an infection for bronchitis. And so I would expect more diffuse inflammation through more of those bronchial tubes, which would cause coughing and difficulty because we've increased airway resistance by increasing inflammation and potential secretion formation. It's going to take more to change the pressure gradient between the atmosphere and the chest in order to get air inside, so it can make it harder for us to breathe, which is different. Any infection of the airways is causing an increase in resistance to get air into the lungs, and it makes it more difficult to create a pressure gradient between the atmosphere and the chest. So that is the key, because those infections do not affect the lung lobule, which is the alveoli. So if I might become hypoxic if I have inflammation of the bronchial tubes just because I can't get as much air in to the lung to begin with. It's different. I might be hypoxic with a pneumonia, but for a different reason. So people sometimes get confused when they're talking about a pneumonia, because most of the time pneumonia only affects the lung lobules. So it's that lung parenchyma and alveoli. Occasionally, pneumonia can be so severe that it's a bronchopneumonia in that it's affected the terminal bronchus and the lung lobule. But mostly it's just that end, it's the alveoli that's inflamed. And so it could be difficult for me to create a pressure gradient between the atmosphere and the chest, only because there's more pressure in the chest to begin with because of the amount of phlegm. But the airway is not the problem. I can get that airway is clear if I can get the air to move. The problem here is inflammation and potential decrease in surface area. I'm affecting Fick's law of diffusion instead. This is the stages of congestion in the lungs with pneumonia. So it's like, say you're looking at a cross section of an alveoli. First, you have, just like we talked about, the vascular phase where there's edema and redness, and then we have what's called the stage of red hepatization, meaning that we're getting more of those neutrophils and congestion. And then then it'll start to change to what's called stage of gray hepatization, where the exudate is more of our problem, and then it has to resolve. So those are the stages of pneumonia. So I would expect a patient could have hypoxia, but it's because of a decrease in surface area if alveoli are plugged with mucus, or an increase in inflammation, which is changing the thickness of the membrane for diffusion. So even though my conducting airway infection and my lung lobule infection, both of them could lead to hypoxia, the mechanism of hypoxia is different. And that is important for the case study and for the coming exam. Pneumonia can be divided into different, the alveoli it's not that they're shriveled, it's that they're full of mucus. So there's no air in it. So in that sense, it's not open like the full grape that could be filled with air. So I'm not sure if that's what that means. It's full of mucus. was I? Okay, so which is different. So that was our bacterial pneumonia, which can be community versus hospital acquired, and certainly has to do with the type of organism that's caused the infection. I mean, you could have viral pneumonia versus bacterial pneumonia. One of our more common viral respiratory infections is influenza, which is an RNA virus. So it's an intracellular parasite that must gain entry into our epithelial cells, and it can take place in the upper and lower airways. Excuse me. Whew, excuse me. So when the virus enters, so here's our epithelial cells that are resting on a basement membrane, and then we have our extracellular matrix and our blood vessels and macrophages and those things, like we've drawn a bunch of times. Every single cell has surface markers on it. That's how our cells recognize each other, but that's also how other cells can attach. So one of the ways that innate immunity works is that foreign material should not be able to attach to our cells because we have different types, different shaped receptors. But what happens with influenza is that it is able to match up. That little RNA virus it has surface proteins that allow, which are these HA proteins. These surface glycoproteins allow that virus to enter the cell and then use the cell to create more virus. The other thing that influenza tends to do is destroy the basement membrane, which is what allows excess mucus to come out. So people who have influenza typically have rapid onset of lots of mucus drainage with fever. We know that viruses, because we remember this from one of the first classes, that when a virus comes into the cell, after it attaches, it has to splice. So this is an RNA virus, which means it has to reverse transcribe itself to DNA. And then it has to splice an area inside our cell to insert itself so that the cell becomes a viral factory. And then we need to be able to get out. So there's a different protein, which is the NA instead of the HA protein, that allows the new virus to bud off and come out. So this is our HA protein, and this is our NA protein. And it's variations in these proteins that gives us our different strains of influenza. And the problem with influenza is that even though we might see similar influenzas every several years, we don't retain immunity well to influenza. We don't retain immunity to most common colds for very long, and that's why we can get those infections again, because our immune system can fight them off, but then the next time, 2 years, when we see that viral strain again, we might not have kept the immune record of how to handle it. So that's one of the problems of why we have to get the influenza vaccine multiple times. The other times is there can be changes in the HA and NA proteins every year. There could be a small drift in those HA and NA proteins, or a major genetic shift, a major genetic rearrangement of those proteins. So, we had H1N1, that's telling you which family of these proteins is what we're dealing with right now, which strain it is. And so there's 3 major families to each of these protein groups, and those have subfamilies. So that's why we require, it's hard to have a universal influenza vaccine, because there's so many different ways that the virus can present depending on the season. So it usually starts out with a rhinotracheitis, which means you have inflammation and drainage from the nose and upper airway, and then that could settle into the lower airways, causing an influenza pneumonia, or so that would be all a viral pneumonia, influenza pneumonia, or it can lead to a secondary bacterial pneumonia. Either way, influenza is deadly, and it does kill several thousand people a year, 30 to 50,000, um, depending on how bad the season is. People will die of influenza, which, of course, as a vaccine advocate, sometimes the influenza vaccine matches better than others, but you cannot get influenza from the influenza shot because that's a recombinant vaccine, which is genetically modified. It's not like the active infection, it's just close enough to mount an immune response. So I always have to throw that in there. So we talked about that. Obviously, now we have a new virus that has thrown our lives into disarray. And that is, of course, COVID-19, which is one of the coronaviruses. So coronavirus is one of the many viral families that cause the common cold. Like there's families of rhinovirus, families of adenovirus, coronavirus, respiratory syncytial virus. There's multiple families of colds that are seasonal. Coronavirus has gone through some mutations before and has led to other outbreaks of respiratory disease. So, and the reason why coronavirus is trouble. Yeah, what's funny, Dawn, that you should say that is when I would give my influenza lecture in the past, because I've been teaching this class for a while, it's been a long time since we've had a pandemic. I mean, you can consider HIV, of course, a pandemic. It's just a slower moving monster, because the incubation period is so long. But the last influenza pandemic, was like over 100 years ago. So I kept saying, like, we're due for a pandemic. And now I'm like, okay, well, I didn't mean that. I really. So I can't say that anymore, and nor will I ever say that again, because it's horrendous. So I don't know, because I'm an idiot. So the coronavirus is a animal virus, and the problem which what happens is with all viruses is that they mutate rapidly, and if the when the coronavirus mutates, it can jump species, and the issue is how easy it is to transmit that virus to other people. What is the community spread? So we had SARS, which was a coronavirus. That's when I worked in the ER. We had the SARS outbreak, but it was harder. You had to have a longer contact with somebody in order for there to be community spread. It didn't spread as easy. So although people got very sick, and they certainly got sick in other countries, and we did have SARS, the first SARS here, we didn't have as many people who were infected, nor as many people that died. The second time that the coronavirus jumped species was a virus called MERS, which occurred in the Middle East, and it was a species jump from camel to people. And people got very, very sick from that, but it didn't easily travel outside of the countries that were affected because there isn't a lot of travel from those countries in some of those countries in the Middle East. So we did not get MERS in the United States. So now we have the novel coronavirus that we're dealing with now. That is a species jump, although not particular. Yes, that's true, Karis. It depends on how it really depends on the incubation period, because yeah, it was deadly. Because if you get illness and have a long incubation period, it's harder to spread it if you're already sick. It's those people who are carriers, unknown carriers, and it depends on how much exactly. It depends on how how virulent is the particular virus, because a very virulent virus doesn't require huge exposure in order to cause an infection. So there's a bunch of factors. However, this virus easily transmits this COVID-19, and the people that get sick, the people that get sick are the people. I have seen it. It's very good. Um, it was certainly a forewarning of what we should have taken a little bit more serious. It was kind of crazy to watch it because I watched it obviously after they kind of focused on the Ebola response. I watched it after this all came about, so it was kind of freaky to watch it. It was very good. Um, so the problem with COVID for some people is that oh, it causes a pretty intense immune response for some people. There's a huge cytokine release, a cytokine storm that causes very bad inflammation in the lungs and can be quite, um, that's the pictures I have, can be quite devastating. I mean, this is our COVID lungs, and so this is a CT scan. This would be the heart, and these where it's like a blackish color is air. That's supposed to be your lungs. Everywhere you see like this irregular white patches is inflammation in the lung. That's a lot of inflammation, um, kind of pooling in the posterior aspect here, which is why people have a difficult recovery, because it takes a while to get rid of that. And that would clearly significantly affect oxygenation. So, okay. Proning. Yep, that's the best treatment actually, is proning. And steroids. At least that's what the latest word is. And I believe that I've been lucky that I haven't, because I work in surgical cancer care, I have not taken care of any COVID patients because obviously they wouldn't have surgery. Um, they wouldn't have surgery if they had COVID, but it certainly has impacted cancer care because people have delayed screenings, people have delayed surgeries. They in the beginning they were not using steroids because there's always a question of whether or not that will decrease immune response. But in this case, because it's the hyperimmune response, it's actually been helpful. So people use dexamethasone. How do you deal with? Yes, I know a lot of people have had to work on COVID floors. I have not, but I feel bad for patients who have major cancer surgeries and can't have their family with them. I can't imagine how horrible that is. So the last part of our lung lecture before we get into the GI stuff is the difference between obstructive and restrictive disorders. So obstruction is disorders of the tubes, and restriction is disorders of the lung lobules, so the alveoli and the parenchyma. So we started out talking about infections that affect the tubes, the conducting system, and the lobules, the diffusion. And now we're going to talk about other types of disorders that can affect either the conducting airways or the lung parenchyma and lung lobule. But these are different. These aren't infections. And one of the key ways we try to decide which is which, I mean, clearly there's other patient has a whole story, there's a bunch of symptoms, they have a history, but they sometimes these diseases can present in the same way, coughing. So one of the ways that we can distinguish between lung disorders is to measure lung volumes, because we would expect them to be a certain amount based on um, sex and weight, but mostly sex. So the lungs can hold 4 to 6 liters of air. Um, And these volumes, the volume that the lungs can hold, can be measured. The tidal volume is the amount of air that moves in and out of the lungs with normal, relaxed respiration. And tidal volume is different depending on the person, and it's usually between 400 and 700 milliliters, the amount of the volume of air that moves in and out. Obviously, just like with the heart, we never operate at full capacity. We're supposed to have some extra just in case when needs increase. So we have an inspiratory reserve and an expiratory reserve. Expiratory reserve volume, inspiratory reserve volume. So we can increase our lung expansion and increase our expiration as needed depending on the needs of the time. So this is our inspiratory reserve volume, and this is our expiratory reserve volume. If I'm using inspiratory reserve and the full tidal volume, that's my inspiratory capacity. If using my expiratory reserve volume and my full tidal volume, that's my expiratory reserve capacity. This is my my vital capacity. Sorry, I'm mixing two words up together. This is my vital capacity, these volumes measured together. You see a space here, which is the residual volume, because we never empty our lung of air completely. That would be bad, because it would be really hard to open them up again. So there's always a volume of air that's left behind. This is something we can't measure because it's inside. So this is a mathematic equation, which you would never have to do. But just to know that this is the total lung capacity, which is different than total vital capacity because I don't use this air. So when people are doing pulmonary function studies, they're trying to measure the amount of air that somebody moves when they are at rest, as well as their reserve volumes when they've increased their activity. And then they do two very important tests looking at the forced expiratory volume in 1 second. So having the patient take a deep breath in and blow out as hard and as fast as they can over a second to see how much air they can move. And then forced expiratory vital capacity, which is the amount of their maximal forced expiration after they've taken a full breath in. And what you get from this is really giving you information about the airways themselves. And this is giving you information about the lung parenchyma and the compliance. So total capacity is telling you about compliance. Forced expiratory volume in 1 second is giving you an idea of how quickly air can move through the airways. And we know that flow is determined by pressure gradient and resistance. So that's what we're looking at. And this would go down if there is some kind of obstruction. And this would go down if there was something that was making the lungs less compliant. So we not only look at these volumes, but we also look at these volumes in comparison or in relation to themselves. So if I had someone with asthma, that's an obstructive disorder of the airway itself because there's scarring, thickness, increased mucus to the airway. The amount of flow over 1 second is decreased. So if I would measure between someone without asthma and someone with asthma, the forced expiratory volume over 1 second for someone with asthma would be low, but there is no problem with the compliance of their lung tissue because the problem isn't the lung parenchyma. So their forced vital capacity should be normal. So this would influence the ratio between forced expiratory volume and forced vital capacity. Whereas if the problem was a restriction, that the lungs were less compliant in general, the forced expiratory volume over a second and the forced vital capacity will both be lower than normal because the volumes are lower in general, because I can't open up the lungs as well as I would like. And so the forced expiratory volume ratio to forced vital capacity, even though both of these numbers are lower than normal, the ratio might be normal because I've still kept the same balance. I'm just lower together as opposed to only one side being lower. Does that make sense? It might be something you have to chew on for a little bit. Kind of. That's good. Sometimes you have to kind of hear it more than once, but that's the main thing we're trying to. What you're trying to do is decide, is the problem that I can't, that the lung is not compliant and I can't take in air to begin with, or is the problem that the lung is compliant? That's fine. It's just that the air is moving slower. Right. Okay, so if I have airway disease, that means yes, not normal, but equal. That's the difference. So if I just looked at the ratio, I wouldn't tell, but if I looked at the actual numbers, actual volumes, I would see, oh, they're lower to begin with. So for the asthma patient, the forced expiratory volume will be decreased, but the forced vital capacity will be normal, because asthma does not affect, it's not a restrictive disorder. It does not affect lung compliance. It will affect speed of airway movement, and the patient will certainly feel like they can't get a breath, but it's not because of the lung parenchyma. It's because of the resistance to airflow. So it's just a different reason. So I could still have coughing, but the reason is different. So airway disease can be a couple different diseases. Asthma is different than other obstructive airway diseases in that it usually has a component of allergy or trigger that, besides causing airway remodeling and secretion, can also lead to bronchospasm. So there is a slightly different presentation, but the concept is the same. Is if I increase airway resistance, it's harder to get air inside the chest because resistance decreases flow. So in the physiology of airway disease, or the pathophysiology of airway disease, there is something that increases airway responsiveness that leads to bronchospasm, which is cough, increased mucus secretion, and a change in the airway itself leading to remodeling. So for asthma, a large portion of asthma is an allergy or trigger related. It's an IgE mediated response. So for some people, we have our mast cell and it gets sensitized to immunoglobulin, the IgE antibodies. For some reason, we have these antibodies that were created against things like trees, pollen, drugs, something irritates or something sensitizes these mast cells. So if the person, cats, something like that. So if the person is exposed to tree pollen or grass or whatever, that will cause the mast cell to release its what's inside of it, which are leukotrienes, which activate the immune response, and histamines, which we know activates the inflammatory response. So we get more mucus and we get more inflammation. The other thing that repeated emptying of mast cells does is release this factor called TNF alpha, which leads to airway remodeling. So the IgE mediated kind of reaction to different allergens can lead to this mast cell dumping. Sometimes it's just that people with asthma, their airways are very sensitive to changes or potential irritants like cigarette smoke or cold air or excessive talking or things like that that can cause an increase in coughing, which is different slightly because there's not the allergy component. In other chronic obstructive airway diseases, those are occurring because um, there is a change in the airways itself leading to inflammation and fibrosis. It's just not allergy mediated. So it could be from chronic cigarette smoking because we know that that chronic stress changes the cells of our airways. And then we get the scarred with increased mucus production. Over time, and for some chronic obstructive airway disorders, they can lead to some issues with compliance. But right here, we're talking about the airways themselves. Here are some of the common causes of chronic obstructive airway disease. Emphysema and chronic bronchitis. This is usually related to smoking, and so is emphysema. So emphysema is a little bit different in that this is our terminal bronchus, and we have our alveoli, which should be like a group of grapes. In order to increase the surface area for gas exchange. When somebody smokes, it can trigger proteases or enzymes that break the walls down between the alveoli. So instead of having this beautiful thing of grapes, we have just one large alveoli. And so right away you can see that we've decreased the surface area for gas exchange because we've lost some of that space. The other thing is there can be airway collapse with any obstructive disorder, which means there's air trapping. And air trapping increases pressure in the chest. And what happens if we increase pressure in the chest? Right, shortness of breath, because we can't pull the air in. So that means we're going to have to use our accessory muscles of respiration in order to create the pressure gradient, because we're going to have to make that container as big as possible because of the pressure issue. So that's some characteristics of emphysema and bronchitis. Just want to get through so we can talk about the GI system. The last slide is just an example of some interstitial lung diseases, which would decrease the volumes completely because they're increasing fibrosis of the parenchyma, so there's less compliance, and that can be a pneumonitis, hypersensitivity pneumonitis, which is kind of what occurred to the people that were having the vaping injury, which we haven't heard about a lot since COVID, because obviously COVID took over. But that was one of the responses to that vape injury that was occurring prior to COVID. Sarcoidosis is another type of change in lung parenchyma where there's a chronic inflammation, asbestos disease of the lungs, where they are just not as compliant. They can't open up as much and accept as much air. And so I do this lecture as a YouTube video too, so I will definitely post that. And then we'll take just a short break till 9 o'clock so I can get the GI thing up. And we'll at least get part of that done before the end of class. So 9 o'clock. Okay, well, we are almost done. We're going to talk about the GI system for the remainder of the time, and then I will post the recordings. So, GI system is basically all made in order for digestion to take place, so that we can get the nutrients we need to do all the jobs that the body has to do. And the GI tract itself is made up of these same layers, no matter where you are in the GI tract. There is the mucosal layer, which is where the mucus is made, and then you can see there's some lymph nodules throughout the GI tract, and the mucus is again part of that innate barrier and keeps this area protected and us protected from infections if possible. You'll see in the submucosa that there are glands, and that's what helps increase the amount of mucus present or decrease the amount of mucus present. And control of those glands rests with the parasympathetic nervous system, because if we're digesting, we do need more mucus in order to flush things through. So that submucosa is really housing the glands and ducts to support the mucus layer inside. You'll see that the mucosa layer also has villi to increase surface area. After the submucosa is the muscle layer, which is circular muscle layer of smooth muscle that's controlled again by the parasympathetic nervous system. But there's actually the body itself, or the GI tract itself, has its own nervous system called the myenteric plexus. It receives information from the parasympathetic nervous system, but it is highly innervated in and of itself, trying to also control peristalsis. And then after that muscle layer is a serosal layer, which is the connective tissue and peritoneum. And you can see that there's lots of nerves there, and that's where the blood vessels come in from the peritoneum to supply the GI tract. And those layers are present to some degree in all aspects of the GI tract. So the enteric nervous system is where we saw in this picture. The enteric nervous system contains nerves that feed the muscle and nerves that feed the submucosa to help with mucus production. And there is autonomic nervous system innervation that helps to increase the frequency or decrease the frequency of contraction or mucus production. So this interstitial cells of Cajal is trying to explain that there is always an underlying peristalsis to the GI tract itself, kind of like how the heart has its own pacemaker that will depolarize on its own and receives innervation from the sympathetic nervous system or parasympathetic nervous system to increase its rate. There are nerve cells that will constantly depolarize in the GI tract at a steady rate, and we can increase the rate or decrease the rate based on the needs of the body. Is it time that we should be working on digestion, or is it time that we need to work on other things in the body during the stress response? So this is how the nerve activity looks in those cells of Cajal. It's a constant rate, sort of like its own little pacemaker, kind of like a heart rate that would favor peristalsis. And autonomic nervous system innervates this it could potentially increase the rate of peristalsis. So that's terrible drawing, but if needed. So the GI tract itself can have multiple types of disorders depending on where you are in the GI tract. It could be trouble with motility, either too fast or too slow. Person could be born with some kind of anomaly to the anatomy of the GI tract. There could be a change in absorption, inflammation, or infection of the GI tract. So here is our beginning of the GI tract, because digestion starts in the mouth with the release of enzymes from the salivary glands that are located around the jaw. And salivation is also controlled by an autonomic nervous system, and we begin digestion of carbohydrates in the mouth. And then we go through our swallow. Half of that is voluntary, the other half is involuntary. So our oral pharyngeal phase, we use our muscles in the mouth and our tongue to move the food against our hard palate and get it into smaller, easier to swallow pieces. And then as we push the food bolus back in the back of the esophagus, the epiglottis closes over the larynx, breathing should be arrested, and the peristalsis of the esophagus, this is an involuntary phase of swallowing. Oops. So this is the muscle movement of swallowing that we just described. And so obviously there can be impairment in swallowing based on the anatomy of the muscles or innervation or strength of the muscles. As we move down, this is showing you the relation of the esophagus with the pharynx, which is right above it. And then as it moves down to the stomach beneath the diaphragm, you can see the aorta and the trachea are wrapped very closely to the esophagus. Oops, that's the esophagus's layers. Again, similar to what we saw, mucus layer, the extra villi, submucosa, muscle layer, and serosa. Esophageal dysfunction could be related to a stricture or reflux disease, ulceration, or hernia. GERD is gastric esophageal reflux disease, which means there's a dysfunction of the lower esophageal sphincter. So when the food bolus gets pushed back to the back of the pharynx, the top of the esophagus, and we have the involuntary part of swallowing, the food bolus peristalsis down the esophagus, and the esophagus then goes through the diaphragm, and that's where our stomach is. This is the lower esophageal sphincter. That sphincter should, when we swallow food bolus, relax to allow food to enter into the stomach, where the food will fall by gravity. And then when the esophageal sphincter closes, there's another sphincter on the bottom here called the pyloric sphincter. The muscle of the stomach engages in churning movements in which this food content is propulsed this way and then drops again, and then it's propulsed. So it's kind of churned around in the stomach acid to start to break it down. If this sphincter is weak, then when these sphincters are supposed to be closed and the muscle contracts and pushes the food back against the sphincter, then food can come up into the esophagus mixed with acid, which will burn the esophagus. So contents should peristalse into the stomach and stay in the stomach. If a person has continued reflux and it starts to cause metaplastic change, then you can develop a precancerous condition, which is Barrett's esophagitis, as the cells begin to change. The next thing that commonly happens in this area is a hernia at the site of the diaphragm. So the esophagus is going down through the diaphragm. So there is, if we were looking at the diaphragm downward, there is a hole in the diaphragm that's supposed to allow the esophagus to go through. Anytime there's a hole in a muscle, that's a natural weak point. So hopefully everything stays like it's supposed to, but if it doesn't, if there's a widening of this open space, then the stomach could potentially come up through the esophagus, or sorry, come up through the diaphragm, and occasionally it'll slide back and forth. And that is a hiatal hernia, where the stomach comes up, out, past the esophagus. So the person would obviously feel, because the stomach's going to get pinched, a feeling of fullness, heartburn similar to GERD, but it's not quite the same. And that might go back and forth because it might slide up and down. Sometimes it's hard to catch when there's a problem with a hiatal hernia. That's different from a paraesophageal hernia, which means that part of the stomach has actually come out and is working itself against the esophagus. These hernias do not slide in and out, and they can be more dangerous because they can cut off blood supply to the stomach. And sometimes they can get so large that a person could have part of their small and large intestine in their chest cavity, which I have seen, and that's a surgery that they would need. Here we are working our way down to the stomach. The stomach, here's its layers: the serosal layer, the muscle layer, the submucosa, the mucosal layer, that is this layer on the top, which you can see the villi to increase surface area, and in these gastric pits where we're going down to increase surface area, we have these types of cells in the gastric pits. We have parietal cells, which we know that parietal cells are essential, as they are the gastric cells, and they also produce that intrinsic factor that we need. And what do we need intrinsic factor for again? Right, we need that in order to absorb B12 later on in the small intestine. So the chief cells help produce mucus, and the enteroendocrine cells also produce different hormones that the stomach is in charge of. So we can develop issues in the stomach in terms of too much stomach acid. So when the person swallows food, that should relax that lower esophageal sphincter to allow food to fall into the fundus of the stomach, like we talked about before. And then the two sphincters should close, and vagus nerve stimulation of the stomach leads to that gastric mixing, where we mix hydrochloric acid with food and expose that hydrochloric acid to help break down the food. The chief cells also secrete pepsinogen, which is converted to pepsin in the acidic juices of the stomach, which helps to start to break down protein in the stomach. So gastric acid and pepsin together within the stomach, those epithelial cells, parietal cells, chief cells, they produce several hundred milliliters of gastric secretions each hour. So when somebody has some kind of GI obstruction or slowing of peristalsis and they want to eat, and they say, well, I'm not going to pass gas or stool or whatever if I can't eat, they should have peristalsis, the movement of gastric juices. So they will still pass gas and have a bowel movement that's liquidy or not normal, because the more you put in there, then the more they're gonna throw up. So it's very essential that the gastric mucosal barrier make the mucus to protect the stomach cells from both the acidic content and the pepsin, because pepsin breaks down protein, and our stomach cells are made of protein. So we have to maintain that protection. If we don't, if we lose the protective mucosal lining, then we could end up with ulceration. So here's like that gastric pit. We're supposed to be creating a mucus layer that's going to protect the stomach itself from the acid and pepsin. If for some reason this mucus layer breaks down, then the gastric cells are exposed to pepsin and acid, and that's a tissue injury with all of its associated inflammatory, correct, all of its associated inflammatory issues. So there are certain things we know that can break down the mucosal layer that we want to keep in there. One of them is H. pylori infection, which I'll show you in a second. The other is NSAIDs, non-steroidal anti-inflammatory drugs, because they block production of prostaglandins, which is good in terms of inflammation, but that decreases production of mucus. Other irritants to the stomach include alcohol, smoking, other diseases near the stomach can lead to issues with the mucus lining. H. pylori is one of the more common things that causes a problem with the mucosal layer, because this particular bacteria, these flagella, the end of that bacteria can spread into the mucus and release enzymes and break the mucus down. So it makes the stomach vulnerable to gastric erosion. And the consequences could be perforation, obstruction if the inflammation is near the stomach outlet, or certainly cancer. And then, of course, insert pepsin, that pepsid of some kind, to try to change the acid environment of the stomach. So now we're slowly moving down the GI tract from briefly the mouth, esophageal issues, stomach issue, and now we're getting to the first part of the small intestine, which is an extremely active part of the digestive process. So eating something goes into the stomach, which we just talked about, into the first part of the small intestine, which has several connections in order to aid digestion. So we have the liver here with the right and left hepatic duct and the common bile duct that's moving down. That's your gallbladder into the small intestine. And then we have the pancreas, which is sort of behind the stomach here, with its pancreatic duct leading down to the same area. Where these two ducts meet, the common bile duct and the pancreatic duct, is here in the small intestine. Here's the common bile duct moving in, and here is the pancreatic duct. They sort of empty into the same place, into the small intestine. Because we want the bile from the liver and the gallbladder to help us break down fats, and we want the enzymes produced by the pancreas, because the pancreas has both endocrine and exocrine function. We want the enzymes produced by the pancreas to come into the small intestine in order to aid in digestion of both carbohydrates, proteins, and fats, because it produces amylase, lipase, and proteases in order to break that food down. So there's a lot of hormones that are also released during this time. When food reaches the stomach, there are hormones that are released, including cholecystokinin, which is a stimulant to the gallbladder to cause gallbladder contraction, and secretin, which stimulates the pancreas to make a bicarb containing solution so that will spill into the small intestine first, because we want here we are where the food ends. We want the gallbladder to contract to help get the bile into the small intestine, and we want secretin, we want bicarb to protect the small intestine from the stomach contents. So we're getting the first part of the small intestine ready to accept food. So This is a highly active area and an area that has a lot of problems, and especially the gallbladder. Um, so the gallbladder is the purse of the liver, essentially. The gallbladder doesn't make anything. It's a storage depot for extra bile. Here's my little gallbladder coming off and connecting to the common bile duct, where it'll then empty into the small intestine. So here's my gallbladder that's supposed to just be a storage depot of bile, and the person eats something and food lands in their stomach. That triggers the release of cholecystokinin, which causes contraction of the gallbladder to allow bile to move down the common bile duct into the small intestine. That's how it's supposed to work. People can have all kinds of gallbladder disease. They can develop sludge or stones in the gallbladder. The main reason why that occurs is supersaturation of bile with cholesterol. So the liver is responsible for the production of bile, and there can be an increase in cholesterol in the bile if the person eats a lot of cholesterol. So one of the main reasons to develop stones is an increase in cholesterol in the bile from increased intake. So it's linked to diet and obesity. That's one of the big reasons why people develop gallstones. But just having a gallstone or cholelithiasis, which is a stone in the gallbladder, does not necessarily mean anything unless the stone is big or the stone often travels. So symptomatic cholelithiasis means that a stone in the gallbladder is causing symptoms, and that would be related to food intake. So if this is my gallbladder and the cystic duct emptying into the common bile duct, and I have a big stone here, every time the gallbladder contracts after I eat food, that stone blocks the outlet for whatever bile is in here. Oh, that looks cute. It looks like some kind of monster. But anyway, this big stone is going to block the outlet, so not as much bile is going to come through as I want to. And so when I eat, I'm going to feel like the gallbladder is contracting against resistance. So I'm going to feel like a colicky, nauseated sort of pain. And over time, I might have an increase in bile inside my gallbladder, which can cause swelling. But I definitely will, from time to time, feel pain when I eat, especially when I eat a fatty meal that requires more bile. And so people will typically discuss intermittent types of colicky pain related to this stone. The other presentation is if this is the same, the person here's their gallbladder, and they have little stones, and here's your common bile duct that's going to make its way into the intestine. If a little stone has to be pushed through, you can have the colicky pain of the stone passing through the common bile duct, and that'll go away once the stone is out and into the small intestine. So that can sometimes be the reason why people have symptomatic cholelithiasis as well. You can develop choledocholithiasis, which means that the stone is stuck. And if the stone is stuck, then you have a greater chance of inflammation. So again, here's my gallbladder into the cystic duct, the common bile duct, which is going up to the liver. And then there is a connection in the duodenum where the pancreatic duct comes in. So if I have a stone here that flicks out, and if that stone gets stuck in the common bile duct, that's called choledocholithiasis, and that means the bile that's supposed to be flowing from the liver and the gallbladder cannot get down into the small intestine. And with this increase in back pressure, there will be inflammation of both the gallbladder and the liver. So the person will have inflammation of the liver, which is what hepatitis means. It doesn't have to be a virus. It just is, that's one of the causes of hepatitis. But another cause of hepatitis is gallstone hepatitis, that a stone is stuck in the common bile duct that doesn't allow for drainage of bile. It could be that the stone gets stuck here, where the common bile duct and the pancreatic duct meet. If that occurs, you can get something called gallstone pancreatitis. So not only is my gallbladder inflamed, but my liver is inflamed, and my pancreas can get inflamed as well, which is never good. You don't want anything wrong with your pancreas. Cholecystitis means that you've developed inflammation of the gallbladder itself. Either the stone is stuck here, right at the outlet, or that big outlet stone is stuck right here. Either way, there's an increase in pressure in the gallbladder because there's bile that's trying to come up, which pushes against the wall of the gallbladder and stretches it, leading to tissue injury. And necrosis, which leads to the inflammatory process, which we all know and love so well. And additionally, this can easily become infected because there's often bacteria inside stones. So we have to worry about that. So this is a common issue, a common primary care complaint, a common reason to present to the emergency department, a common reason to have surgery. We certainly don't want anything that will eventually lead to pancreatitis, which is inflammation of the pancreas. And there are the 3 top reasons for inflammation of the pancreas. The number 1 is gallstone pancreatitis, it's gallstone disease. 2 is alcoholism. And 3 is related to a genetic disorder of triglycerides, which gums up the pancreas. So we definitely want to prevent that from happening. The problem with the pancreas, since its exocrine function is to produce amylase, lipase, and protease, is able to break down sugar, fat, and protein. That's what all cells are made of. So if I cause obstruction of outflow of those pancreatic digestive enzymes, it will be activated instead inside the pancreas. And since the cells of the pancreas are made of sugar, protein, and fat, the pancreas essentially auto-digests itself, which leads to a huge cellular injury, necrosis, hemorrhage. It can become infected. It's a big old mess, essentially. That's a picture of a pseudocyst or a large fluid collection that's occurred in the pancreas. And once the pancreas is inflamed, it takes a long time for that to get better. Moving down, we have our liver. Our liver has many, many jobs. Many of these jobs we've talked about along the way. We talked about its job in terms of making proteins like albumins. It is part of the production of steroid hormones as well as the production of cholesterol packaging when we want to create the very low density lipoproteins and high density lipoproteins. It's part of storage of iron. It is involved in the metabolism and removal of excess bilirubin and the production of bile. It's part of first pass and detoxifies the things that we eat. It saves us from ourselves because there is a portal circulation between our stomach and our small intestine, and our liver would be right here with its ducts. But the other thing it has, is a set of veins that communicates between the liver and the small intestine only. And any vascular communication between just 2 organs, because this circulation is not the general circulation, this is a portal circulation, only sharing blood flow between the small intestine and the liver. When I eat and drink and take medication or drugs, it will be absorbed through enterocytes into the portal circulation and pass through the liver first, in order to be hopefully detoxified or metabolized. So that's very nice of the liver to do that for us. You should be thanking your liver. So it has a lot of essential functions. It's very vascular. It has both bile circulation, rich vein supply, and arterial supply. And we know it's very important in terms of our bilirubin and bile removal. So that goes back to the lecture about red blood cells. When red blood cells have gone through their lifespan, in normal circulation, they get caught up in the spleen where they are broken down into its component parts. The globulin is the protein part. The heme is broken down into porphyrin and iron. We know that iron travels on transferrin and can be delivered into the liver as ferritin or delivered to the bone marrow for renewed red blood cell production. It will go through several enzyme reactions and become bilirubin as well. When that bilirubin is free bilirubin, we need to manage that bilirubin. So it gets conjugated so that it can be part of the bile circulation and it can be removed from the body through urine or stool. So the bilirubin and the ability to manage bilirubin are a way that we can monitor how well the liver is working. If there's an increase in bilirubin, that means something's going on with the liver. And it could be that there's a problem with increased amount of bilirubin because of hemolysis, like we talked about before. So that would be a problem above the liver, meaning we've had an increase in red blood cell destruction because of a hemolytic anemia or some kind of problem. So there's just too much bilirubin for the liver to work with. Not that it can't do it. It could be an intrahepatic cause, meaning direct liver damage, cirrhosis from hepatitis infection or non-alcoholic fatty liver disease that actually changes the way the liver is able to process bilirubin. Or there's an obstruction of bile flow. And we just talked about a post-hepatic cause of an elevated bilirubin, which was choledocholithiasis, a stone getting stuck in the common bile duct. So if there's an injury, well, we probably should leave off here. So where I'm leaving off is, and this part is probably more important in terms of the final assessment, is fat accumulation or the intracellular accumulation of fat in hepatocytes. So there are some pretty good videos about that, and then I have my own thing which I will put up so that you can see that. But the issue is that intracellular accumulation of fat can lead to an inflammatory response that ultimately could lead to liver failure and is fast becoming the first cause of liver failure above alcoholism in this country, especially given our obesity epidemic. Some of the other slides are talking about absorption issues in the small intestine, and then diverticulitis in the large intestine, and then discussion of anal pathology as well. So that'll be in the YouTube video. I will open up the case study and post those videos. And the remaining minute, does anyone have any questions? Or you're just all like, oh my God. It's a lot. Boom, boom. Nice one. Nice one, Candy. I feel like I have a diarrhea. I know. That was pretty quick. So I definitely will post those YouTube videos too, because that'll help you. That doesn't beat my 5-minute cancer talk. Maybe I just can't think anymore. Why is too much bilirubin bad? I feel like I should know this. Because it'll start to cause accumulation in other structures. So your body's only meant to have a certain serum content of bilirubin in the bloodstream. So once the bilirubin increases, there will be an attempt by the rest of the body to increase bilirubin, to take in bilirubin to protect. We don't want that much in the bloodstream. So that's what causes the jaundice. So I increase bilirubin in my skin cells. I can also increase bilirubin in my brain cells, which is ultimately the worst thing because that affects, that can lead to encephalopathy, and that could ultimately be, my undoing, and that's the worst thing that could happen, causing brain damage. Um, but you're going to start to see, once the bilirubin starts to increase, you're going to see more evidence of bilirubin in the urine and stool. You'll see the white stools and the dark urine. You're going to start to see evidence of bilirubin being pulled into skin cells. So you're going to see it, but ultimately what you're worried about is that bilirubin is going to be pulled into brain cells. Yes, connectors. That's what we were worried about. I mean, it's not pleasant to have bile salts in your skin. It increases diarrhea. It's very itchy and uncomfortable, but I don't want it in my brain. I'm just seeing what Amanda is typing. Thanks. I just had a patient that really got to me, and long story short, came in with abdominal pain and found a internal. Yeah. Sometimes people will come in with painless jaundice too, and it's like it's already too much. It's infants that are most sensitive to bilirubin increases. Yeah. In terms of their brain function. But as bilirubin increases, it's also telling us that the rest of the liver isn't functioning correctly. So they're going to have other increase in other waste products like ammonia and stuff like that. Alrighty, guys. I know I hate cancer. Too much cancer in the world. Have a good week. We're almost done. Keep pushing to the end.
Thank you very much.
Sure, guys. Bye.